Hello everyone and welcome to our module on congenital adrenal hyperplasia. Congenital adrenal hyperplasia is an enzyme deficiency syndrome that is caused by loss of one of the four enzymes necessary for cortisol synthesis. The four enzymes are shown on the slide here. A 21-alpha hydroxylase deficiency is the most common cause, and we'll go through all four of these syndromes in the next few slides. In the video on the adrenal glands, I talked about how the adrenal cortex synthesizes mineralocorticoids like aldosterone and glucocorticoids like cortisol, and also androgens like testosterone. All of these substances are derived from cholesterol via the adrenal cortex. In the congenital adrenal hyperplasias, one of the enzymes necessary to make cortisol is missing. For example, the most common enzyme deficiency is 21-hydroxylase, but you can also find deficiencies of any of the other enzymes shown in this slide that are necessary to make cortisol. Now, all those reactions and enzymes and intermediates shown on the last slide are very hard to remember. What I'm going to give you is my own simple system for answering board questions about congenital adrenal hyperplasia. And if you want to answer board questions, all you really need to know is what's on this slide right here. So cholesterol can be converted by the adrenal cortex into either aldosterone, cortisol, or androgens. In the congenital adrenal hyperplasias, some enzyme is missing so that cortisol cannot be synthesized. That will drive up the amount of ACTH, and that will drive cholesterol into something else. Since it can't become cortisol, it will become either aldosterone or androgens, and this is what leads to all the symptoms of the congenital adrenal hyperplasias. So in all of these disorders, because of some enzyme deficiency, there is low cortisol, which stimulates ACTH release from the pituitary, and this can cause increased production of the other hormones, as I just said, like mineralocorticoids and androgens. In addition, the low cortisol drives up the ACTH, and that causes adrenal hyperplasia, and that's how these disorders get their names. The result of the adrenal hyperplasia, however, is not more cortisol synthesis. That cannot occur because of an enzyme deficiency, so instead you get an increase in some non-cortisol hormone synthesis. All of the congenital adrenal hyperplasias are very rare. The reason the boards like to ask you about these disorders is because they use them to test whether you can recognize the signs and symptoms when a particular hormone is present in excess or when it's deficient. So let's talk about that now, and let's start with cortisol. So in all of the congenital adrenal hyperplasias, there are low cortisol levels. And remember, these syndromes occur in a baby, so the baby is not going to verbalize that it feels fatigued. Instead, the signs and symptoms in a baby are going to be hypoglycemia and nausea and vomiting. Remember that cortisol raises your blood glucose levels, so when it's low, there can be hypoglycemia. And then nausea and vomiting are classic symptoms of low cortisol levels in adults who present with adrenal insufficiency. They often look like they have a GI illness. For aldosterone, the signs and symptoms all depend on sodium and potassium. Remember that aldosterone promotes sodium retention by the kidneys and potassium excretion. So if there is a congenital adrenal hyperplasia syndrome where aldosterone synthesis is deficient, this will lead to sodium loss by the kidneys, and anytime sodium is lost in the urine, water follows. This will lead to hypovolemia and can progress to shock. In addition, there will be hyperkalemia because the kidneys are not excreting potassium normally. And then finally, renin levels will be up because the kidneys are trying to correct the deficiency, but they can't correct it because the adrenal glands are not normal and can't produce aldosterone normally. When there is aldosterone excess in a congenital adrenal hyperplasia syndrome, the signs and symptoms are the opposite. So there's sodium retention by the kidneys, and this leads to hypertension. In addition, there is hypokalemia from potassium loss, and then renin levels will be low because the kidneys are trying to correct the aldosterone excess, but they cannot. For androgens, the signs and symptoms depend on the chromosomal sex of the child, whether the child is XX or XY. If there are excess androgens present as part of an adrenal hyperplasia syndrome and the baby is female with 2X chromosomes, she will be born with ambiguous genitalia. If the baby is male, that child will develop precocious or early puberty. Normally, puberty doesn't occur until the testes begin making lots of androgens, but if lots of androgens are coming from the adrenal gland, then that can lead to early puberty. If there is androgen deficiency present and the baby is female with 2X chromosomes, she will have normal appearing external genitalia. If it is a male child and there is a severe androgen deficiency, that male child can appear female at birth. If there is some androgen production but just lower than normal, that can lead to ambiguous genitalia. And this is a picture of what ambiguous genitalia can look like. You can see how it's difficult to tell whether this baby is male or female. And anytime you see something like this in a board question, what you want to think about is the underlying physiology. This occurs in females who have excess androgen exposure or males that have an X and a Y chromosome that have deficient androgen exposure. Let me briefly mention the effects of high levels of ACTH in the adrenal hyperplasias. The main effect of ACTH in adrenal hyperplasias is to stimulate the adrenal gland. However, high levels can also sometimes cause darkening of the skin or skin hyperpigmentation. The reason for this has to do with a hormone called melanocyte-stimulating hormone, or MSH. This hormone shares a common precursor protein in the pituitary gland with ACTH. That precursor is called pro-opiomelanocortin, so when lots of this is being made to synthesize lots of ACTH, that can also lead to high levels of MSH, and that can increase melanin synthesis and darken the skin. This is sometimes seen in congenital adrenal hyperplasias, although it's a classic finding in Addison's disease in adults when they develop adrenal insufficiency, but you should be aware of it because in a board question of a baby with adrenal hyperplasia, they may describe darkening of the skin. So if you understand those principles we just went through, then it's very easy to understand the congenital adrenal hyperplasias. We'll start with a 21-alpha hydroxylase deficiency. This is the most common cause of congenital adrenal hyperplasia. And in this disorder, what happens is cortisol cannot be synthesized because 21-alpha hydroxylase, the enzyme, is deficient. In addition, these babies cannot make aldosterone because you also need 21-alpha hydroxylase to make aldosterone. So as a result of the low cortisol, the ACTH levels go up, and that causes adrenal hyperplasia. That drives lots of cholesterol into androgens because that's the only thing the cholesterol can be used to synthesize without 21-alpha hydroxylase functioning normally. So these babies have deficient aldosterone symptoms, deficient cortisol symptoms, and excess androgen symptoms. This is the classic cause of congenital adrenal hyperplasia. It's responsible for 90% of cases. These babies can have low cortisol symptoms, low mineralocorticoid symptoms, and excess androgen symptoms. So remember, if it's a girl child with two X chromosomes, that can lead to ambiguous genitalia. If it's a boy, that can lead to early onset or precocious puberty. Now in real life, there are variable symptoms based on enzyme levels. There's a classic form where these children are severely deficient in 21-alpha hydroxylase. There are also non-classic forms where children have up to 50% of the normal enzyme activity. You can read about all the different subtypes of this disorder in your textbooks, but you don't need to know all that for step one. You just need to know the underlying physiology. So in the classic salt-losing form, this is the most severe form of the disorder. These babies are born with a marked deficiency of cortisol and aldosterone. So they have nausea and vomiting, volume depletion, hyperkalemia. This usually presents in the first 7 to 14 days after birth. In addition, they can have ambiguous genitalia if they are female. In the milder forms, cortisol and aldosterone production can remain intact, and the main finding can be from the excess androgens. So in females, this can lead to ambiguous genitalia, and as I said before, in males, this can lead to precocious puberty. Next, let's talk about a 11-beta hydroxylase deficiency. So children who are born deficient in this enzyme cannot make cortisol, just like all forms of congenital adrenal hyperplasia. They also cannot make aldosterone. However, they can make a substance called 11-deoxycorticosterone. This is an intermediate in aldosterone synthesis, and it has weak mineralocorticoid effects. For that reason, children who have this condition, even though they can't make aldosterone, they will have a buildup of 11-deoxycorticosterone, and that will lead to an excess of mineralocorticoid effects. And then finally, these children overproduce androgens because they are unable to make cortisol and aldosterone normally. So this disorder is similar to 21-alpha hydroxylase in many ways. There can be low cortisol symptoms depending on the severity. Girls can have ambiguous genitalia, boys can have precocious puberty. The main distinction between this disorder and the classic form of congenital adrenal hyperplasia from 21-hydroxylase deficiency is that there is increased mineralocorticoid activity in 11-beta hydroxylase deficiency, and that's what they want you to know for your boards. They are testing your understanding of the underlying physiology. So there are high levels of 11-deoxycorticosterone, which is a weak mineralocorticoid. This will lead to hypertension and hypokalemia, which is not usually seen in 21-alpha hydroxylase deficiency. Next, we'll talk about a 17-alpha hydroxylase deficiency. In this disorder, cortisol production is deficient, just like in all the adrenal hyperplasias. Also, androgen production is deficient, but aldosterone production is intact. So these children are born with deficiency of cortisol and androgen and an excess of aldosterone production. 17-alpha hydroxylase is part of a larger cytochrome P450 enzyme called P450C17, and this cytochrome enzyme is found in the adrenal glands and in the gonads. What this means is that children born with a deficiency of 17-alpha hydroxylase will be unable to synthesize androgens in both the gonads and in the adrenal glands. The larger enzyme catalyzes two reactions. One is the 17-hydroxylase reaction, the other is the 17-20 lyase reaction. If we go back to this slide showing all the reactions in the adrenal cortex, the larger cytochrome P450 enzyme catalyzes this step, the 17-alpha hydroxylase step, and also this step, the 17-20 lyase step. All you need to know though is that when 17-alpha hydroxylase is deficient, this leads to underproduction of androgens in both the adrenal gland and in the gonads. So children with this disorder, depending on the severity, can have signs and symptoms of low cortisol and signs and symptoms of excess mineralocorticoids like hypertension and hypokalemia. However, what really distinguishes this disorder from all the others we've talked about before is the low androgens, and this is because of that cytochrome P450 enzyme found in the adrenal glands and the gonads. It's very high yield to be able to recognize the signs and symptoms of androgen deficiency due to any cause, including this form of congenital adrenal hyperplasia. If the baby is a male with an X and a Y chromosome and the androgen deficiency is severe, the external genitalia may be entirely female. On the other hand, if there is some androgen production, then the external genitalia can be ambiguous. Internally, there will be an absence of a uterus and fallopian tubes. This is because the child is male and it has Sertoli cells present in the gonads which secrete Müllerian inhibitory hormone. In addition, there will be undescended testes. This is because the testes depend on normal androgen levels to descend into the scrotum normally. In a female with two X chromosomes, the baby will appear normal at birth. However, that baby will develop primary amenorrhea at puberty. She will not menstruate. Why does this happen? That's because her theca cells cannot produce androgens, and androgens from the theca cells are used to make estrogens like estradiol. So this female will have low estradiol levels at puberty, and thus she will not develop secondary sexual characteristics and she will not begin menstruating. So if you understand all this, then it's very easy to understand that this congenital adrenal hyperplasia is often diagnosed at puberty. A female with two X chromosomes may fail to develop secondary sexual characteristics. A phenotypic female who is actually a male may fail to develop at all because this male lacks a uterus and lacks ovaries. At this point in time, a workup is done and hypertension and low potassium are identified. So often the cortisol and mineralocorticoid symptoms are mild, so they're not diagnosed in childhood. It's only at puberty that the disorder becomes apparent. The last adrenal hyperplasia is a 3-beta-hydroxysteroid dehydrogenase deficiency. In this disorder, children cannot make aldosterone, cortisol, or androgens. This is very, very rare, and I'm not even going to go through all the clinical characteristics. You can figure them out yourself if you know which hormones are deficient. In the reproductive section, I have a video on disorders of sexual development, and in that video I talk about how when babies are born with ambiguous genitalia, the first thing you want to know is the chromosomal sex of the child. If it is a female with two X chromosomes, then there is some source of excess androgens, and this is often because of congenital adrenal hyperplasia. As we just discussed, the most common form of CAH involves excess androgens, and if that occurs in a girl, that can lead to ambiguous genitalia. There are other causes of ambiguous genitalia in a female, but one of the things you should definitely think about is that most common form 21-hydroxylase deficiency in a female child. If you see ambiguous genitalia in a male, then there is a lack of androgens. Either androgens aren't being synthesized or they can't exert their effect. And this is very rarely due to CAH. This can happen in some of the less common forms of congenital adrenal hyperplasia, but in the video on disorders of sexual development, I talk about a lot of other things that can lead to this problem. So ambiguous genitalia in an XY male is much less likely to be due to adrenal hyperplasia as compared to in a female. Some states screen newborn babies for congenital adrenal hyperplasia. The way they do this is by measuring the level of 17-hydroxyprogesterone. Why do they measure this level? It's because it's elevated in the most common form of adrenal hyperplasia, a 21-alpha-hydroxylase deficiency. If we go back to this slide, 17-hydroxyprogesterone is metabolized by 21-hydroxylase into 11-deoxycortisol. I think it's pretty low yield to know all the intermediates on this slide, but if you want to remember one of them, remember 17-hydroxyprogesterone because that level will be elevated in the most common form of congenital adrenal hyperplasia. The treatment of adrenal hyperplasias is complex and it's not something you're expected to know for step one, but you should be familiar with the underlying physiology principles. So many forms are treated with glucocorticoids, and this should make sense to you. These drugs replenish cortisol levels and stop the pituitary from making so much ACTH. This will lower the ACTH level and stop the overproduction of other hormones. In addition, in forms of CAH where mineralocorticoids can't be produced, you can also treat these patients with mineralocorticoids. The drug that's usually used is fludrocortisone. It's a drug that has the same effects of aldosterone. If we go back to this slide on the 21-alpha-hydroxylase deficiency, if you treat the patient with glucocorticoids, that will raise the cortisol levels. That will stop the overproduction of ACTH, and that will stop driving cholesterol into androgens. If you then also treat the patient with fludrocortisone, you will replace the aldosterone effects, and this is the way you can treat these various forms of congenital adrenal hyperplasia. And that concludes our video on congenital adrenal hyperplasia.